everybody. My name is Amir Faraji, and I'm going to be doing my presentation on the Barrett's esophagus. So, before I begin, just a little bit of introduction by myself. You know, that handsome young man next to Vince Vaughn is me right there, with the puffed up jacket or whatever. So, that's me. I went to University of Arizona for 4 years in Tucson. I studied biology down there and played rugby for a few years. Couple more things about me. I'm aspiring to become a dentist. I've been in the field since I was 12 years old, and I love every bit of it. And I love camping. And what what 20-year-old, what 24-year-old does not love to travel all around the world? So that's my main goal. I really just want to get out there, experience every culture the best way I can. So, without further ado, let's get into Barrett's esophagus. Woo! So a little bit of history about Barrett's esophagus. So before it became known as Barrett's esophagus, in 1906, a man named Wilder Tileston. So he started noticing peptic ulcers that were being found in patients that closely resembled those in the stomach. And then fast forwarding to 1953, surgeons named Philip Allison and a radiologist named Alan Johnston, where they examined the esophageal lining and observed in 7 patients with reflux esophagitis. And all those 7 patients had advanced adenocarcinoma. And then they presented it to a surgeon named by Norman Rupert Barrett. And Mr. Barrett took these into consideration. He pretty much published the idea of Allison and Johnson. He took those ideas and published them. And then, whenever you publish something that's yours, you get to name it whatever you want to. So that's how it became Barrett's esophagus. So it's not that Norman Barrett discovered it. He just kind of took the idea, and then he was the one that was able to publish it for them. But about him is that he incorrectly identified what it was because he thought they were ulcers. That's not the case. Barrett's esophagus is really, he misinterpreted the findings of Allison and Johnston by saying they looked like ulcers. But, you're fast forwarding to 1976, where it was the first biopsy that was able to confirm that there were cells from the digestive system that were present in the esophagus. So goblet cells, junctional, and gastric epithelium cells that were present, all cells that are known, the stomach and the intestines and other components of the digestive system. So as you can see here, you have Wilder Tileston. He was the one that first discovered it. Peptic ulcers located in the esophageal region. In the middle, you got Norman Barrett. That was the man who published the idea and was able to name it after himself. And then I couldn't find a photo of the radiologist Alan Johnston, but right here you have Philip Allison. So now I'm going to get into more of the components on how this disease is caused. So the main cause of Barrett's esophagus is
gastric esophageal reflux disorder, GERD.
And this is because it causes irritation of the esophageal squamous lining towards around the gastroesophageal junction before it gets into the stomach. So now it's impaired due to a variety of different things. You can have a poor diet consisting of foods that are high in fat concentration or that are acidic, smoking, hiatal hernia located at the sphincter, all of these that cause weakening of the sphincter and allowing acid reflux to occur and irritate the lower part of the esophagus before it enters. Now, some substances that enter from the digestive system into the esophagus are pepsin, which is a known digestive enzyme, stomach acids such as hydrochloric acid or potassium chloride, and other contents from the duodenal, which is the beginning part of the small intestine, such as lipase, protease, and amylase. All of these are cells that break down food. And so some symptoms of
GERD,
pyrosis, chronic cough, laryngitis, or insomnia. So as you can see in this image, you can see on the left, you have a healthy stomach with the sphincter that's closed, separating the stomach acid from the esophageal lining. Whereas on the right, you have a patient with a GERD, and it's a weakened sphincter, and this allows the stomach acid and other components of the digestive system to the lower part of the esophagus. So, what is Barrett's esophagus? Well, Barrett's esophagus is when you have chronic GERD. That's what Barrett's esophagus is, and with so you have pretty much four stages of Barrett's esophagus. You have low grade, which is nuclear hypochromatic, and they're large, and the low grade one is not as severe because it doesn't breach the surface of the epithelial cells, but it causes loss of surface maturation in the esophagus. And then you have the next one, which is cryptdysplasia. And the main biomarker where you know you're in this type of stage is when you have an increase of P53 expression. P53 is a known component to fight abnormal cell division. This this biomarker is activated to control the cellular proliferation. High-grade dysplasia, which is when the nuclei is enlarged and there's lost architecture. It's kind of you're leaning more towards now we're getting into the adenocarcinoma. Adenocarcinoma is cancer. So this is when at this point you're gonna have dilated dysplastic glands, which are ulcerative, and they cause necrotic debris, and it also causes invasion of the squamous layer in the esophagus. So as you can see in the histology of these different events, you have so the picture to the far left is a normal cell. It's well organized. Nuclei are at a normal level. It's all stacked properly. There's no breach. Whereas in the middle, you have a cell that's composed of Barrett's esophagus. So a Barrett's esophagus, the way you could tell that a patient has it is by seeing that these are columnar cells. These columnar cells, as you can see, it's kind of enlarged compared to just regular stacked cells in squamous lining. And then once you reach into, if you see the far right, this is the histology of adenocarcinoma, and you can see, these cells are rapidly proliferating, the nuclei are enlarged, and it's not, there's no structure to it. There's no proper composition of it. It's just kind of staggered all over the place. Some signs and symptoms of Barrett's esophagus. Well, there's generally no symptoms with Barrett's esophagus. People normally experience symptoms due to
GERD.
I mentioned those symptoms earlier. Now, if you take those symptoms into account, and if they persist for longer than 3 years, like you still are getting frequent heartburn every day, and so on and so forth, that's when it's time to seek medical attention. I guess there are some different signs that they can tell. So some signs are erosion of the squamous layer near the gastroesophageal junction. So just around the esophageal sphincter, you could see that there's increased irritation. And there's the biggest one is the digestive cells that are present. So as you saw from the histology of my last slide, you could see that the Barrett's esophagus, when you start seeing columnar cells versus squamous cells, that's when you've already advanced. So when you look at this image right here, this is how you could tell when someone's advanced to Barrett's esophagus. You could see that there's normal squamous epithelium. It's nice, pink, and ready to go. Whereas the Barrett's esophagus, it's kind of degenerated, just not normal anatomy of the esophagus. And that's a good indication of knowing that somebody's advanced to that stage. So to test the histology, there's a couple of testing methods that are conducted. So you have the traditional method, which is endoscopy, and you also have esophageal capsule cytology. So endoscopy is where a camera that travels through the esophagus, taking pictures of the esophageal lining and pictures of all different components of the body. So you have two different methods. You have the esophageal route, which travels through the oral cavity A patient has to, this was the first method intended and has been proven great accuracy. However, the patients have to be sedated in order for this type of procedure to be performed, because the camera could be pushing on the back of their neck and it causes them a gag reflex, and the camera can't sufficiently go down that way. So they have to be sedated. They've been trying transnasal route. This is not as invasive as going through the oral cavity, because instead of going underneath the epiglottis where it causes a gag reflex, it goes over the epiglottis and then down, and then guides its way down the esophageal route. So you don't have to worry about that gag reflex, and you're able to sufficiently diagnose the patient. So this is a non-invasive procedure, and the patient does not have to be sedated. So a lot more patients these days have been going down the transnasal route because of this. And going back to that image I showed you guys, this is what you normally would see in a patient with Barrett's esophagus that's traveling down, where the endoscopic method is traveling. And you could see, these are the two, this is how they administer it. So as I said, on the left, you have the esophageal endoscopy where the patient is sedated, making it easier for the physician to insert the camera and travel down the esophagus. Whereas on the right, you have the nasal endoscopy where, like I said, they go over the epiglottis and the patient is awake during this portion. Another method that for testing it that's been introduced in 2007 was the esophageal capsule cytology. Now, this is the first non-endoscopic testing method where, like I said, does not require any sedation, and it's pretty much what they do is they have a capsule, they layer it with gelatin that a patient swallows, and this capsule is attached to a string, and when the patient swallows this capsule, it rubs against the entire esophageal lining, traveling down to the gastroesophageal sphincter. And then at that point, when the physician feels like they're close to the lining, they just pull it out. They pull it out, and there's no pictures or anything examined. However, they do look at the cells that this capsule rubbed against. So as you can see in the photo to the right, that's how the capsule looks like. That's the gelatin layer they put over it in figure A. And then in figure C, it travels all the way down to about, maybe a little bit past the stomach, probably once it enters. And then they pull it out. The patient is not sedated for this kind of procedure. And then you just examine the histological state that the esophagus is in. So as you can see in figure E, you have the columnar cells, and that's consistent with the histological. With this slide, if you could see here in the middle, you could see is exactly what figure E looks like, and that's a detection of Barrett's esophagus. There is treatment for this. There is treatment, but the best time, once you're in Barrett's esophagus, it's kind of hard to reverse it back. So the best type of treatment is to stop it when you're in GERD, where the best component is to, have a well-maintained diet, reducing the amount of high-fat foods, the amount of acidic foods that are in your system to not cause a reflux disease. But however, if that doesn't work, there also, you could take patient can take antacids such as like protein pump inhibitors, and these prevent transition to Barrett's esophagus. However, if a patient is in the current state of Barrett's esophagus, there's a couple things that they could do to help maintain their current state. So, for example, they take cyclooxygenase inhibitors such as aspirin or non-steroidal anti-inflammatory drugs. And what these do is when a patient's already at a stage of Barrett's esophagus, at this point, it's all about preventing them from getting cancer or adenocarcinoma. So if a patient ignores the treatment or doesn't comply with it, they could advance to adenocarcinoma. So a dysplastic Barrett's esophagus or early adenocarcinoma, the best method is endoscopic therapy. Now, endoscopic therapy is pretty much where they go down the endoscopic route, but now they're, instead of diagnosing, they're trying to treat it. So now you have a couple different ways you could do it. So the most commonly used one is radio frequency ablation. Now what this is it generates thermal injury to the affected sites. So they go down the endoscopic route, and at the tip where the camera would normally be, they use thermal energy to just remove all the cells that are not known to the esophagus. Or so that's the most frequent one. But there's other methods. So they have the cryotherapy, where pretty much it's kind of like it's in the sense of freezing off a wart, where they use liquid nitrogen or liquid CO2 and freeze the area to induce tissue damage and remove the tissue proteins from the esophagus. Now, the last method is the photodynamic therapy. And this is where a photosensitizer drug, such as profimer sodium or tetrahydroproxyl phenylchloride, is taken by the patient. And when they take this medication, it kind of marks the affected areas in the esophagus. Where they go down the endoscopic route, there's a laser that targets the affected area. So as you can see in this photo, you have in the top left, you could see that the radio frequency ablation. You can see the tissue damage that is being caused by it, and all the bleeding and so on and so forth. And on the right, you have the cryotherapy, where it's spraying liquid nitrogen or liquid CO2 on the affected areas, freezing the components, like I said, to induce tissue damage. And at the bottom, you have the photodynamic therapy. So you have the affected area in the image. Of the three images, the one on the left of the photodynamic therapy, you have in that white area, that's the affected site. The patient has already taken the photosensitizer drug. You could see like the kind of area that it marks, so that when the laser comes in, as shown in the middle photo, it already affects those areas and it targets them for damage. So this is pretty much the end of my presentation about Barrett's esophagus. Now, it's one of those diseases that it's hard to detect because there doesn't show any symptoms. However, there are gastroesophageal reflux disease is definitely a key component. So if a patient is diagnosed with that, it is critical for them to seek medical attention from their physician. Well, I hope you enjoyed my presentation on the Barrett's esophagus. I hope you learned a little bit about myself and this disease that affects it doesn't affect a lot of people, but it affects a good sum of them. So here's my bibliography, and I hope you enjoyed this presentation.